about the imaging evaluation of child abuse.
You don't hear me, that's a problem.
You talk about the imaging evaluation of child abuse, and I would like, first of all, to reassure you, it's really a topic that is related to violence, but we won't see any shocking images here. So there are several categories of child abuse, and as radiologists, we will be involved only in the diagnosis and evaluation of physical abuse. Regretfully, it's a worldwide problem, and it's very easy to get statistics from the USA. So in 2010, there were almost 700,000 children that underwent maltreatment, and that's less than 1% of all the children in the US. Approximately 80% of these were object of physical abuse. That's less than 0.2 of all the children population. In Israel, the situation is not better really, and approximately 2% of children underwent any kind of abuse. I couldn't get data from France. And I hope that at the end of this talk, you will know how to manage the evaluation of child abuse. You will be familiar with all the wide range of findings in child abuse. You recognize the classical findings, and you will be aware when to raise the suspicion of child abuse. I will be talking only of the imaging of the head and of the skeletal imaging. I won't talk about the abdominal thoracic imaging because this is more rare, and usually it's indeed neglected because the children come with polytrauma and everybody is busy with a head injury and nobody looks at the thorax and the abdomen. So how they present clinically, these children? They may come with some history of trauma, something. In other instances, they come for the evaluation of non-specific neurological signs, and so our working diagnosis is to rule out encephalopathy, encephalitis, and metabolic diseases. Now let's say this 5 months girl comes in with a history of trauma. Should we do a skull radiograph, yes or no? And there is not a good answer to that, because it depends really on the center you are in. In many places, still it's popular for the initial screening in kids less than 1 year old to do a skull radiographs. In our center, we'll do all the 3 views, the AP, the lateral, and the town. In other places, they do just the AP and the lateral, and they decide whether to do the town. And here, this light is really a little bit interfering. You see there should be 2 fractures, which is already quite suspicious. Now, if the child comes really with a suspicion of child abuse, and we are dealing about neurological, head trauma, neurological problems, what are the indications for going on to further evaluation, to CT? And in these cases, the indications are very, very liberal, especially under 24 months of age, under 2 years of age. And then, naturally, if there are neurological signs, the kid will go for further imaging. But if there is no neurology, but there is a history, suspicious history of head trauma, then we'll perform CT as well. Now there is also a group that is considered high risk. Children with skeletal fractures or with facial fracture, or any child below the age of 6 months is considered high risk, because we really can't judge very well their neurological signs. And also, if there is no neurology at all, but there are clear signs of abdominal or thoracic injury that are suspicious of abuse, we will do the head examination as well. Above 24 months of age, about 2 years age, if there are no signs of any injury or no neurological signs, so there won't be any indication for imaging on the head. Lately, the ACR is also added the possibility to perform MR in children below 2 years or above 2 years who present with neurological signs if the MR is immediately available, so that's a good option as well. And we use the CT because, you know, it's still the first line in urgent cases. When we have to perform the examination now, so it's available, it's quick. If there is need to treat, so we can do it immediately. It's a very good modality to diagnose fracture and to diagnose all kinds of hemorrhages. Really, the CT was considered to be inferior to the plain film of the skull to detect fracture because we could miss linear fracture just in the plane of the scan. But today we do the 3D reconstruction and then we see very clearly all the fractures and we know what we're dealing about, what is a suture and what is a fracture. And if we see fractures that are multiple or bilateral or stellate or depressed, then we are, and the history doesn't match, then we are suspicious of a child abuse, because let's look at these two fractures. Okay, bilateral. The only way to get such a fracture is really to get a trauma smack here on the top, to fall just here on the top of your head. And if the history doesn't match, so something is wrong here. What are the most common findings of child abuse? And this is a large meta-analysis based mostly on CT. And the most common finding is the subdural hemorrhage, and usually multiple hemorrhage. Actually, in another series of 93 kids with subdural hemorrhage, under the age of 3, 50% of them were cases of abuse. So it's really a red light, the cerebral hematoma. And in the young age, in the infants, we very commonly see it along the interhemispheric fissure. It can be in the posterior interhemispheric fissure, in the anterior interhemispheric fissure, and anywhere, really. Sometimes we can also see contusions. And again, the contusion, and again, the subdural. But the most severe sign and the most severe finding are the parenchymal injury that may be very extensive, that are really non-contusional, and they are not in vascular territories, and we don't nearly know what's the mechanism. That's probably due to hypoxic-ischemic injury, because in the flexibility of the neck, stretching of the brainstem, and the cervical cord causes injury to the respiratory centers and episodes of apnea. Now a very important teaching point that I've been telling you again and again, but I'll state it clear. So we should be very suspicious of abuse when there is a mismatch between the severity of the reported incident and the severity of the injury. Yes, that's a very important point. Because, you know, the usual story, the child comes in that he has fallen from a changing table, or from a couch, or from a mother's hand, and that's a low fall injury. It's a meter or something like that. And we know that in such falls, what we can get a scalp injury, we can get a linear fracture, only one, we can get a little subdural at the region of the fracture, and maybe we can get a contusion, poop and contrast poop, but not more than that. Not multiple hematomas, not large subdural hematomas, no huge parenchymal damage, so it doesn't fit, the history doesn't fit. Okay, now Now let's look at this case. Usual story. Kid fell from mother arms. We do a CT, and what we see here? We see a subdural, but this acute subdural, it really seems upon a chronic subdural. There are large collections here, and then we have a little blood in the ventricle, and then we have a little blood here upon the sagittal sinus, and then we have this huge hypodense lesion. So that's too much for a low fall. Too much and very suspicious. Another important point is that the lesions are age different. They are from different ages. It's not so important the exact timing to say, okay, this happened a weekend ago and this happened a month ago. That's not so important, but only to understand they are from different periods. So there is an interval between one is acute and one is chronic. And because repeated abuse is very much suspicious for a repeated trauma is very much suspicious for abuse. So again, usual story, and we see here a contusion, and we see chronic unacute subdurals, and we see that he has got injury on both sides. So that's too much for a common household fall. CT is available, is very reliable. However, there are some points that are really the CT has some problems with, because these children not always come immediately after the trauma. Sometimes they arrive 10 days, 2 weeks after, and then on CT we won't see the hemorrhage anymore. And also the timing, especially of the extra-axial hematoma, is difficult. And surely MR is better for the detection of parenchymal lesions. So even if today we are very much aware of the radiation consideration, the risk for benefit for the acute episode is for the CT. But later on, we would like to proceed to MR. And what are the indications for MR according to the ACR? All cases of suspected abusive head trauma with CT abnormalities, we will continue to MR to see the full extent of the lesions. Or, opposite scenario, we have no CT findings, but the child is neurologically impaired. We don't know the reason, so we should do an MR and see what's going on. And here, on MR, it's much easier to really see the acute and chronic subdurals. Okay? Here on CT, acute, a lot of fluid here, but maybe it's a middle age with an acute bleed. But on MR, clearly we see the membranes in the subdural collection that are indicative of a chronic subdural and the acute bleed. So the situation here is much clearer. And also what I mentioned, kids come 2 weeks after the trauma. We don't see any subdural here anymore. But on MR, it's obvious that it's not clear fluid, that there has been there hemorrhage. And we can readily distinguish between two episodes, these two subdurals after different ages. And all this is data that is very important in order to ascertain that there is an abuse here. As well, the MR helps us to detect injuries and subdural in very specific locations, which are, let's say, in the vertex or on the base of the skull, and subfrontal along the tentorium, that are more difficult to diagnose on CT. And that's only a thought, yes, that's a theory, that all the subdurals are probably due to tearing and thrombosis of the bridging veins. We have to remember that with all the advantages, MR is also limitation. it's less sensitive for the detection of hyperacute subdural hemorrhage, because the hyperacute hemorrhage will look exactly as the CSF. Here on the left side, and this is from Van Osborne, we can see that it behaves exactly like CT, like CSF, and on CT, from CT, we knew that there is a bleed there. So in the acute, again, CT is sometimes the better. And also, if we look for a subarachnoid hemorrhage, we can have a problem. In the system, we have a problem because we are looking for the hemorrhage, subarachnoid hemorrhage with a FLAIR protocol. So in the basal system, we can have artifacts from flow of CSF. It looks white, so we can detect anything that is not real CSF here. And also, okay, this is coming out very, very dark, in children that are under anesthesia and are getting 100% oxygen. So the FLAIR is sometimes not really good in annulling and making the CSF completely black, and then it would be difficult to pick up a subarachnoid hemorrhage. But the MR is really